This conference will now be recorded.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I started now recording the session. So if you miss something in this session, you can find it, inshallah. I will put it on YouTube, so you can find it later, inshallah. And on the WhatsApp group, I will send the link of the video on YouTube, inshallah. I am Dr. Osama AKL, MRCOG. I am from Egypt. Today, inshallah, we will have orientation session about how to prepare effectively for the most challenging part of MRCOG, which is part 2. It's more challenging than part 1 and part 3. Part 1 is easy. Most of who join part 1, they pass the exam. Okay, while part 3, it's not very difficult. Part 3, it's just depends upon training, practice. Then you apply, then you pass part 3. But the one that is full of knowledge,
PDF ഇട്ടിട്ടുണ്ടല്ലോ.
the one that need much studying, the one that has many sources for knowledge, it's part 2. The material and the syllabus for part 2 exam comes from Green Top Guidelines, NICE Guidelines, Scientific Impact Paper, and from top articles, from some articles from British Journal of Obstetrics and Gynecology, and from Faculty of Sexual and Reproductive Health, and from BASH Guidelines, Behavior Guidelines, and many other sources, in addition to strategy and other sources. And I don't think it's something practical and something can be applied that somebody can read all these sources. Very challenging, very challenging. To read a guideline about certain topic and read 60 slides or 60 papers in single topic, something very difficult. We are gynecologists, we are obstetricians. We have always busy schedule, busy at hospital, busy at home. All of us have this challenge. That's why we try, inshallah, to make it more easy by making everything concised and by comparing the same information in multiple sources. Because sometimes in the exam you find he asks you according to NICE, then he asks a question. Another question, according to Faculty of Sexual and Reproductive Health, then he asks a question. So you have to know what is the source of the information and how this information is different in multiple sources. You will think it's difficult, but inshallah it will be easy. By repeating the information more than once in the course, you will find that you are memorizing automatically, inshallah. In addition to studying, nobody said that there is no studying, there is a studying. As long as you started the way for MRCOG, you are a doctor searching for the best in your career. So you need to do something. You need to do some effort. Okay. Part 2, as we said, is the most challenging one, multiple sources of knowledge. But inshallah, here in the course, you will have one source of knowledge, which is the PowerPoint of the course. All the course is made in the form of PowerPoint. So you don't need to open any guideline. Again, you don't need to open any guideline. All information, inshallah, is summarized, concised, and written in a good way to be easily memorized in this course, inshallah. Part 2 needs hard working, from attending the lecture, from studying the PowerPoint and the video of the lecture after that, because all members of the course, they have the material present online, so they can study the PowerPoint and the video until the exam. You are not alone. As long as you started this way, you are not alone. We will support you, and also your colleagues and your study partners will support you. Don't walk in this way alone. It will be more difficult. You should have a study partner. And You will find that brainstorming, one of the very good things that can help you in this way. For example, you study a topic, your study partner studied another one, you sit together, you say what you know, and he says what he knows. It will be more easy like that. You will find that in the exam, inshallah, you will find that you remind and you remember the words I said, and you will remember my voice. And also you will remember the voice of your study partner when he said certain information while you were studying together. This happened to me personally. In the exam, I remembered some of my friends' voice when they were saying this information. So don't be alone in this way. You have to support each other. Your colleagues will support you, and you will support your colleagues. Don't walk in this way alone. On the opposite side, don't be among many people. What do you mean? I mean that don't have 20 study partners. No, no, no. This is a miss. This is a miss. You should have 2, maximum 3 study partners. Why? When you choose small amount of doctors and you study with them and you are sure they are studying hard, when they say something, you can ask him, what is the source of this information? And you are sure he is studying well. You can depend upon his information. But for example, when you are studying on a Facebook group containing 1,000 members, for example, everybody will say information. You don't know which one's right, which one's accurate. You don't know even if somebody is saying this information, depending upon UK guidelines or American guidelines, which is not used in our exam. That's why no need for many study partners. No, no, no. You need 3, maximum 4, but choose them. Choose study partners that they have similar condition like you. It will be more better if they are talking the same like your language, and they have similar condition like you, and you know they are studying hard. Now you can rely upon and depend upon what they say to you, and any information they say in this situation will be reliable and dependable. So Facebook groups, Telegram groups are good to tell you what questions came before in the exam, to give you some questions from some sources, but the answers you have to ask, what is your evidence for this answer? And I believe the source is more important than the answer itself. Don't depend in the exam studying that you know the question and its answer. Then you go to the exam waiting to see the same question to choose the same answer. This is common mistake. This is common mistake. And as our doctor said, Dr. Yasmin, already the RCOG is trying to reduce the number of recalls as much as they can. They know that doctors have recalls, they read them, memorize them by heart, go in the exam, and put the same answer for the same question they studied before. They know this, and they are trying to prevent this by making restrictions upon the recall questions, and also by not repeating recall questions. So you'll find gradually they are trying to reduce the number of recall questions in the exam. They want that the doctor who pass the exam, they want to be sure that already this doctor studied well, and this doctor has already got information. Why? Because after having part 1 or having part 2 exam, you can go and work there as MTI. So they want to avoid that a doctor to be going to work there as MTI only by memorizing by heart some recall questions and solving them in the exam. That's why they want the doctor who studied well. They want the doctor who had good information. Even for your knowledge and for your career, are you satisfied by passing this exam only by solving recalls, only by solving questions? Will you be satisfied if you pass this exam and you know in your heart that you passed this exam by chance, and you pass this exam that you studied some recall questions and passed? Are you satisfied from your heart? Take care. Information is not only important for part 2 exam, they are also important for part 3. Anybody who studied well for part 2 will find it easy to pass part 3. If you study well for part 2, you don't need to check your knowledge again for part 3. No, already you studied, already you had the information. And the opposite is true. If you have poor studying for part 2 and you passed, and this happens, you will find it difficult for passing part 3. The problem, part 3 can cost much money, and part 3 only 4 trials are available for part 3. Doctors who don't pass part 3 in these 4 trials will join again and need again to enter part 2 exam. That's why this is your chance to have the best knowledge, not only for the exam, but also for your career. You will find much difference in your practice. You will find that in your hospital, your attitude towards patients changed. And even you will find that your knowledge improved. Your colleagues are looking at you in a different way because you studied well. So don't be alone. You should study well in this exam. Of course, up till now, on the website of MRCOG, they didn't put up till now accurately when will be the coming February exam. You know that doctors, we are going to have July exam, which was going to happen after 2 months. The exam is deferred and it became in September because of coronavirus. Allah protect you all. But inshallah, we expect that February exam will be in its due time. Usually it will be in the first Tuesday in February. Here I put the time of the last one. And if you look at the calendar, you can guess what will be the next Tuesday in the next February. It will be the first Tuesday next February. Okay, I know that all of you didn't apply, didn't have the application, didn't book the exam up till now because booking for the exam didn't start yet. Because of the current condition in the world, it's the first time to start the course very early like that. Okay, so you will be more lucky to have more long course. Okay, so you will have enough more time for studying. Let's talk about the previous February exam, the last February exam. Booking started in 26th of August and it closes after about 20 days. So we expect that next August booking for 2021 will start and will close after 20 days. And please, booking for the exam became more crowded than before. What do you mean? In my exam in 2016, I booked part 2 exam in the last day of booking and a seat was available, no problem. But with time, with passing years, the exam becomes more and more crowded. Many more doctors trying to have MRCOG because it's a very respected certificate. That's why, please, as long as you are intending to have February exam, you have to book the exam in the same day when booking starts. Why? Many doctors were late to book the exam and they were surprised. When they opened the website trying to book the exam, they found that the venue present in their country is fully booked. So they may try to defer the exam to another time, or they may think of traveling to another country to have the exam. Make it easy for yourself. From now, if you are intending to have the exam in next February, so you have to book the exam, inshallah, in the same day when booking starts, inshallah. So always follow the MRCOG website to know when booking will start, so you can book in the first day. Better to be in the first hour of booking starting. The fees of the exam. They classify countries according to categories. Okay, UK, Ireland, category A, category B, category C. Why they made this category? Okay, they know that not all countries can pay same fees for the exam. We have countries can pay more, countries can pay less. That's why they made categories for this. Okay, you can know your country is according to which category from this website. You will find there a table in listing the countries and saying each country category A or B or C. So the fees of the exam is variable, as you see. The venues. The routine venues for the exam. In UK, we have multiple: London, Manchester, Edinburgh, Dublin. International, many venues: Bangladesh, Egypt, Hong Kong, India. So this list is always changing and always updating. That's why even they write on the MRCOG website always that venues TBC, to be confirmed. To be confirmed. That's why this is a routine, but it's a variable from one exam to the other. Okay, what is the format of the MRCOG Part 2 exam? Because I know that some of you didn't join the exam before. The exam is in one day of 2 sessions. So we have 2 papers, paper 1 and paper 2. We have 2 formats of questions. We have single best answer and we have EMQ. So first the paper, 3 hours, then 1 hour break. I call it the golden 1 hour. Then the second paper, again another 3 hours. So you stay there in the hotel for the exam more than 7 hours. Exhausting, yes. But you have to know what are the tricks to avoid exhaustion in this day. You are studying months, maybe studying more than a year. Some studied years for the exam. So you have to be trained well how to avoid being exhausted in this day. Exhaustion will cost you much marks. You have to avoid it. And I will train you how to avoid being exhausted in this day. So we have 2 types of questions, single best answer and EMQ. Each paper containing 50 single best and 50 EMQ. But the marks are not equal. 60% of the marks for EMQ questions, 40% for the marks for single best answers. That's why, as you see, passing in EMQs will help you much to be successful in this exam. If you solve EMQs in the right way, mostly you pass the exam, inshallah. And now, as you see, we have 2 papers, each one single best EMQ. So we have four categories. Paper 1, single best. Paper 1, EMQ. Paper 2, single best. Paper 2, EMQ. We have 4 types up till now. Is it a must to pass the 4 types? No, not a must. We need total score to be higher than the score needed to pass. So even if you didn't pass in a single best answer paper or single EMQ paper, there is still a chance, if your score is good, to pass this exam. Throughout the course, you will be trained, inshallah, how to solve the questions. From discussion happened with Dr. Yasmin, I want to confirm upon a point that sometimes while you are in the exam, you think the question is difficult, while the examiner put to you everything you need to reach a single answer. Sure that the model answer is containing 1 answer for each question. So you have to reach and you have to know and you have to guess which answer was written in the model answer for this question. So he put all the steps inside the question to help you to go to this answer that was written in his model answer. I know that they are trying to make it difficult by making the questions and making the options near to each other. You will find, is there a difference between answer A and answer B? I think it's the same. No, it's not the same. It's not the same. To solve this dilemma, we have technique for solving the question. If you read the question, then you start searching in the options upon the answer that can be right. I am sorry, this is not the right way. So what is the right way? The right way that you read the question well, single time. There is no time in the exam to read it twice. You should read the question single time, but read it well, with concentration, and put a line under the keywords. Okay? After reading the question one, now you know in your heart what is the diagnosis, what is the situation. Okay? So you can guess the answer. Now there is answer in your mind. Now you can look to the options for the first time. So prepare an answer before looking at the options. If you look at the options before guessing an answer in your mind, okay, you will find, oh my God, I think multiple options, they are near to each other, they are the same, it's a difficult question. If you try this method, you will find it's more easy to solve. Read the question, prepare answer in your mind, then start looking at the options. Search for the answer that you put in your mind. You find it? Excellent. Mostly you are right. But please, have another look at the options. Is there any other answer than the one you prepared in your mind? Then tick the answer. This is the right way to solve. By this way, do you find, does it matter? Is it single best answer or MQ? No, it doesn't matter. The same technique. Read the question single time well with concentration, highlight the keywords. So I am reading the question. Mrs. X, she is 35 years old, she is pregnant, 20 weeks. Okay, put a line under 20 weeks. Previous to cesarean section, put a line. It was classic cesarean section, put a line. Classic cesarean section, so and so and so. Now I know what is the question about. I know what will be the answer. I look at the options. I found my answer. I see it's the best one among the others. Inshallah, it's a right answer. On the opposite side, he can put some tricky points in the question. And sometimes he can put something to distract you. He can put additional information that's not needed. Or he can put an information that he wants to know if you know that this doesn't affect the answer or not. While you are in the exam, reading each question, ask yourself what the examiner wants to test me in this question. Because he is testing you in a certain information. He wants to know if you read this guideline or not. So a patient with small 4 gestational age baby. Okay, alhamdulillah, I read this guideline. He is testing me in a certain point in this guideline. After reading the question, you know now which part from the guideline he is asking about. Now you can know what is he searching for. Clear so far? Any questions so far? Clear? Somebody say clear. Awake? Are you awake? Hello?
Clear.
Clear, sir. Clear,
Okay.
sir.
Fine. I know that you are fasting and you are tired and maybe you wake early to attend the session, but inshallah, it will be very useful to you, inshallah. Somebody have a comment about what I said? Somebody has any comment? Okay. let's continue. Bismillah. So you have to be trained about how will you plan for the exam day and the day before. Okay, as we said, exhaustion and anxiety, they lead to losing marks. So you have to know how to avoid an anxiety, how to avoid the stress, how to avoid being exhausted. Okay, that's why some doctors tell me, Dr. Osama, your lecture is long because our scientific day takes about 4 to 5 hours. My friend, in the exam, you will stay 7 hours. If you are exhausted in the lecture, and if you are not trained to attend long lectures, how will you attend the exam? You will be exhausted in the exam, which is very big problem. Okay, what about previous courses? Okay, always after every course, I publish on Facebook and on WhatsApp, congratulations for our doctors who passed the exam. Okay, so here, this is the post I made since 3 years for our friends who passed after having this course in July 2017. Alhamdulillah, multiple of them became even MRCOG instructors, and many of them completed all MRCOG already. Okay, this was the first course, July 2017. Okay, this was Jan 2018. Congratulations, these doctors. I know that some of you already may know my course, that one of these doctors who passed the exam is one of their friends and told them about the course. Okay, this was for July 2018 exam. Okay, from Egypt, Algeria, from Iraq, Pakistan, India, Algeria. Okay, this was for January 2019 from India, Pakistan, Iraq, Egypt, Malaysia, Nigeria, Sudan. Okay, and also I publish specific congratulations for some doctors. This was January 2019. This was for July 2019. Okay, from Egypt, India, UK, Pakistan, Sudan, Bangladesh, Palestine, Libya, Iraq. Okay, let's talk about the new course that, inshallah, our first lecture will be, inshallah, after 2 weeks. I will show you the table. The components of the course: long course from 38 to 40 scientific days. Each scientific day, we have about 4 to 5 hours lectures. Okay, with breaks in between, of course. These lectures from long course cover all the guideline. Dr. Osama, 40 is a big number. Dr. Osama, 5 hours is a big number. I am sorry, I am trying to increase it more and more. I will not be happy if somebody went to the exam and Dr. Osama, there was a topic we didn't discuss. That's why I'm trying to cover all topics and even took articles, trying always to cover more and more took articles. So the longer course is very important. Okay, then there are monthly exams. I will show you an example for these monthly exams. It's something new, started with the last course. Then condensed crash course in the last months before the exam. That we have 6 scientific days. Each scientific day, we have about 10 to 12 hours lectures each scientific day. You may think it's unimaginable. you will pass this trial. You will have this experience. Condensed crash course, very important. Okay, to summarize and gather the most important points in all topics. Okay, it will be confirmatory for doctors who joined the long course, in addition to new topics present in the crash course, and it will be life-saving for doctors who didn't study well for the exam. And mock exams in the last 2 weeks before the exam, so you can be trained to solve how to solve large number of questions in small number of minutes, because time management is very important for the exam. You may find a doctor who studied very well, studying since 1 year for the exam, but he couldn't finish all questions in the exam. Time management. Another doctor studied 1 year for the exam, but in the exam was anxious, so he couldn't concentrate well, he couldn't read the question, and he couldn't answer well. Exhaustion must be avoided. Okay, the time of sessions. We will start, inshallah, as we said, in June. Inshallah, it will be single session per week. Okay, this is February 2021 exam. We will start, inshallah, to be single session per day, and single scientific day per week, each Tuesday. Sorry, because I got it from the previous course. Each Tuesday. We will start 2 p.m. Cairo time, which is 1 p.m. UK time, because now 1 hour between UK time and Egypt time. So you can know easily what will be the time in your country. Okay. These are some of the topics that to be covered in the course: systemic lupus, phenylketonuria, diabetes, DKA, early pregnancy problems, small ectopic and miscarriage, trophoblastic disease, hypertension, collapse, small for gestational age, recurrent pregnancy loss, cord prolapse, cholestasis, thrombocytopenia, anti-RBCs antibodies, cardiac disease, preterm labor, psychiatric disorders, neurological disorders, including headache, epilepsy, and other diseases, breech, cephalic version, nerve injury, GPS, intrapartum care, operative delivery, cesarean section, VBAC, Ogilvie syndrome, VTE, thromboprophylaxis, ovarian vein thrombosis, breast cancer, asthma, appendicitis with pregnancy, multiple pregnancy, skin disorders, renal diseases, liquor abnormality, amniocentesis, hemoglobinopathy, sickle cell and thalassemia, and other types of hemoglobinopathy, antepartum hemorrhage, postpartum hemorrhage, placenta accreta spectrum, postpartum hemorrhage, IOFD, abortion care, reduced fetal kicks, induction of labor, abdominal incisions, TOG articles, antenatal care, teaching, thyroid diseases, infertility, contraceptions, female genital mutilation, menopause, ovarian cyst, non-menopausal and post-menopausal, infections with pregnancy and gynecological infections, prolapse, laparoscopy, hysteroscopy, urogyny, endometriosis, irritable bowel, inflammatory bowel disease, endometrial hyperplasia, cancer cervix and cervical screening program, the new protocol, endometrial cancer, obesity, Essex, social problems with pregnancy, hysteroscopy, abnormal uterine bleeding, sexual abuse, governance, vulval disorders and cancers, ovarian cancer, ergonomics and laparoscopy, sepsis, post-menopausal bleeding, fertility and thyroid, and statistics. These are not all the topics that will be covered in the long course, inshallah. And This is a list of the topics to be discussed in the crash course. It contains much of topics already discussed in the long course. So I summarize, make them concise, what is the most important thing in each topic, in addition to some important topics for the exam. Okay, so again, long course, monthly exams, crash course, and mock exams in the last weeks before the exam. Okay, from where we will study? You will study from the material on the Google Drive, and inshallah our website will be published within 1 month, inshallah. On my website, you will find all the PowerPoint lectures and all the videos, so you can study from them after attending the online session. So you don't need to open nice talk articles. You will study from the course material, inshallah. This is a screenshot from Google Drive. You will find day 1, day 2, day 3, day 4, each one containing the PowerPoint and the video like this, containing the PowerPoint and the video of the lectures discussed in this day. Okay, and the videos also are summarized on another website on Vimeo, the videos of the course. So you will be attached to one of these channels containing the videos of previous topics, and it will be updated after each lecture by putting the new videos. Okay, some of the feedbacks about previous courses. Okay, I made the names anonymized. These are screenshots from WhatsApp. Okay, other screenshots. Okay, in addition to this, we have WhatsApp group. Okay, so if something not easy in the lecture, something you find it confusing in the lecture, we can discuss it together after that on WhatsApp. Okay, somebody has any questions so far?
No, Doctor, you can continue.
Yes. You have a question?
No, you can continue.
Okay, okay. In this slide, each sentence is a comment from a doctor. Okay, I was asking them a question about the feedback of the course, and 1, 2, 3, 4, 5, 6, 7, 8 comments from 8 doctors. Other comments from 5 doctors. Again, other comments. Okay, what will be the timetable of the course? Inshallah, the first lecture will be in 2nd of June, inshallah. Okay, 1 p.m. UK time, and we will start a single day per week. And then after September exam, we will be twice per week, Tuesday and Friday. Tuesday and Friday. So at first, single day per week, each Tuesday. After September exam, Okay, it will be twice per week, inshallah. Then in January, there will be the crash course because the exam in February, inshallah. Okay, thank you. Somebody doesn't know how to do search on MRCOG website and on NICE guidelines. Somebody doesn't know? Somebody doesn't know how to search for a TOG article? Do you need to explain this or you know it?
No, sir, we know it.
You know it, excellent. It's very important. You should know how to search for a guideline. Okay, and from where you can find the guidelines. Clear so far? Somebody has any question? I am ready to receive questions. Okay, inshallah, we will start now our scientific topic.
Hi, Dr. Osama.
Inshallah. Yes?
Sorry, I came late. I asked about if you will discuss module-wise or not.
Yes, look at this. You are talking about the 14 modules? Talking about the 14 modules, doctor?
Yes.
This is your question? Hmm?
Yes.
No, look, I don't care for the 14 modules. Why? Because in the exam, you will find that he is classifying the exam paper into 14 modules. No, it's not like this. And even in your real life, it's not divided into modules. Okay, the most important thing to cover all the topics. I am not classifying it into modules. Okay, because you may find single topic, it can be under multiple modules. So the most important thing to cover all the topics, not important to be module wise.
Yes.
Okay.
Okay. Okay.
Okay. The exam is not divided, and even you'll find paper 1 in the exam, some gynae questions, some obstetric questions. The same in paper 2. Some gynae, some obs. So it's not classified. And sometimes a doctor asks, doctor, paper 1, is it gynae or obs? And the part 2, is it gynae or obs? Why is this question? Is it important? Not important. Whatever it's a gynae or obs, you need to answer. We want just everything that helps us to pass. We will start now, inshallah, scientific topic. It's a free gift for all of you. It's an important book article called phenylketonuria. Phenylketonuria. It's a talk article. It's an important one. Came before in the exam multiple times. That's why it's important. And it's a small topic. Okay, let's have something from the physiology. Okay. When you eat a protein meal containing a material called phenylalanine, your body will take this phenylalanine and convert it into tyrosine. This tyrosine, from this tyrosine, your body can make dopamine. Dopamine is an important neurotransmitter. And also your body can make melanin pigment, important for the skin, for the eye, for the hair. And this tyrosine will be taken also to make multiple body proteins. So you eat protein converted to tyrosine. Tyrosine will give multiple products important for the body. Here comes the importance of an enzyme. It's called phenylalanine hydroxylase enzyme. Phenylalanine hydroxylase enzyme. This enzyme is important to convert phenylalanine into tyrosine. So here is a question. What if a patient has phenylalanine hydroxylase enzyme deficiency? Dr. Yasmin, if somebody has deficiency in this enzyme, what will happen to phenylalanine?
It will not be converted into dopamine, melanin, and certain body proteins which are needed by the body.
So phenylalanine itself, what will happen to it if this enzyme is deficient? Increase or decrease?
It will certainly increase.
Excellent. It will accumulate. The bad news, it's toxic if accumulated. It will be toxic material. Okay. What will happen to tyrosine? Increase or decrease?
Happen to tyrosine or thyroxine?
Tyrosine will decrease.
Tyrosine will decrease and phenylalanine will accumulate in the body, and it will cause nerve damage and demyelination of the fibers.
Excellent. So dopamine will be decreased. So there will be neurological and CNS manifestations because it's important neurotransmitter. Melanin will be defective. So pigmentation of the skin, of the hair, of the eye will be defective, and the body proteins will be decreased. Body proteins decreased in the baby, so talking about IUGR. Body proteins defective in the child, so talking about poor growth, neurological and physical. Excellent. Thanks, Dr. Yasmin. Very good. So a question. What is the main problem is phenylketonuria. Let me say BKU. BKU, phenylketonuria. The main problem, deficient phenylalanine hydroxylase enzyme. Okay, so phenylalanine will increase, tyrosine decrease, so the coming products will not be produced, will be deficient, and they are responsible for the syndrome and the problem of phenylketonuria. What is the meaning of phenylketonuria? It means phenylalanine will accumulate, so its level in the urine will increase. This phenylalanine will be toxic, as we said. Okay. The incidence, 1 in 10,000. So it's from rare to very rare. We have what's called colloquial. What is the meaning of colloquial? From this colloquial, you can know if this disease rare, common, very common, uncommon. We will be trained about how to use it because questions about colloquial comes in the exam. Okay. Are there many cases in UK suffering from this condition? We are talking about 3,000 to 4,000 person in UK having this condition. Okay. From the previous slide, the first step that you eat food containing phenylalanine. If you have deficiency in the enzyme, the coming problem will happen. So if the patient has this enzyme deficiency and we reduce the amount of phenylalanine in the diet, everything will improve. Yes, that's right. But take care. Take care. If you do so, body proteins will decrease. Excellent. So we know two things. Number one, we will decrease the diet containing phenylalanine, and I will give protein supplementation not containing phenylalanine to avoid malnutrition. Okay, very good. Very easy. No, not very easy. Why? Because you will prevent multiple types of food which contain phenylalanine. And also, another difficulty is that the food supplementation, the protein supplementation, always they have not good tests. That's why control is not easy. Control is difficult. But if done, everything will be fine. Okay. The baby inside the uterus, how to be affected by this condition? the baby can be affected by one of two types of conditions. Either the baby itself having enzyme deficiency. So this baby will be a case of PKU. Or the baby is chromosomally okay, no problem in the chromosomes, no problem in the genes of this baby, but the mother herself having PKU. So phenylalanine will pass through the placenta to the baby, and the baby will suffer. Some babies will have both suffering. The mother deceased, so the baby will be affected by excess phenylalanine transplacental. The other problem, the baby can be genetically abnormal, having itself the PKU condition, so can suffer from one of two sources: affection from the mother or having the disease itself. Some babies will have both conditions together. Okay, the one here on the left, the baby is genetically normal, but the mother is a case of PKU. So phenylalanine is passing in large concentration against concentration gradient to the baby. What do you mean? I mean that the level in the umbilical cord in the baby can be even higher than maternal level. How come? Active transport. Oh my God. Active transport, yes, against concentration gradient. This question came before in the exam about concentration gradient. So concentration in the umbilical cord can be 1.5 to 2.5 fold the concentration in maternal blood. So the baby will have IUGR, microcephaly, small head, very important. And we will know what is the meaning of a small head, how to know, how to diagnose. Congenital heart disease, 7 to 10% in comparison to 2 to 5% in the general population. So congenital heart is more common. So we will say we need to do ultrasound to exclude congenital heart disease. Microcephaly, so very important to measure biparietal diameter and head circumference. Head circumference is more important. IUGR, so we need serial growth scan by ultrasound each 4 weeks in pregnancy, starting from 24 to 28, to exclude having IUGR. Intellectual and developmental disabilities, yes, CNS is affected. Facial dysmorphism, you will find that both sides of the face of the baby are not typically the same. It's a problem in the growth. And skin rash. These manifestations, okay, they are similar to manifestations of, here comes the exam question, manifestations of
Alcohol syndrome.
Yes, that's right. The manifestations of a baby to a mother with PKU is similar to fetal alcohol syndrome. Fetal alcohol syndrome, exam question. Fetal alcohol syndrome. Very important point. Fetal alcohol syndrome. Okay. So on the right side, that this person became a child. What will be the manifestation? Again, microcephaly, the head still small. Neurological problems, epilepsy, abnormal skin odor, because this baby is having excess phenylalanine, so abnormal odor, skin eczema, behavioral problems like hyperactivity, problems in the language, and by MRI, you can find structural changes in the brain. So we will know what will be the appearance in the newborn and what will be the appearance in the child. Very important number for congenital heart, 7 to 10%. Very important. We said tyrosine will be deficient, so dopamine will be deficient, melanin will be deficient, and body proteins will be deficient. In this picture, as you see, the color of the skin, color of the hair, manifestations of tyrosine deficiency, and manifestations of melanin deficiency. Okay, learning disability, mental retardation, epilepsy, skin rash, behavioral issues. And the color of the eye will be blue. Blue color of the eye, manifestation of melanin deficiency. So while we are controlling this condition, it's very important to have serial measurement of phenylalanine level in the blood. Very important. This is your target. You have certain level. You need to achieve it. How to achieve it? Diet control. So we need to involve dietitian in the management. And we know what he is going to do. He will tell the patient, avoid these types of food that contain phenylalanine. And he will give protein formula, not containing phenylalanine. Is it important to do this control throughout all the life? The answer is no. Why no? Because it's not easy. We said you will prevent many types of foods and you will give supplementation with bad test. So do this only when you need it. The question, when I need it? You need it in the embryo. So the mother should be controlled. Not only during pregnancy, even pre-conception. Number two, in the children, because of neurological development, behavioral development, so we need good control in the child. A woman planning for pregnancy, because you have target of phenylalanine pre-conception. So pregnancy can happen while the woman is nearly to be controlled. And during pregnancy. So important for the woman planning for pregnancy, during pregnancy, and the children up to 7 years. Okay. What is a normal level of phenylalanine? Normal level below 120. This is a normal level of phenylalanine. Okay. When it becomes increased, we have multiple levels. Level number 1, hyperphenylalanemia, up to 600. Level 2, mild phenylketonuria, from 600 to 900. Moderate, from 900 to 1200. Classical, and in this classical, the phenylalanine hydroxylase enzyme is almost completely absent or severe deficiency. That's why phenylalanine will be more than 1200. Important numbers. So normal, less than 120. Up to 600, hyperphenylalanemia. 600, 900, mild. 900, 1200, moderate. Classical, more than 1200. Important. It can be just a question in the exam asking you about the grade of BQ. How to treat? As we said, involve dietitian. And we know he will prevent multiple types of food containing phenylalanine and give protein supplementation. And we will need good control pre-conception. So we will try to adjust. And when the condition becomes controlled, then we allow pregnancy to happen. And during pregnancy, still we need monitoring. And we said we need to monitor the baby. Serial growth scan, echo for the heart to exclude congenital heart because it's 7 to 10%. Okay, and we need to monitor phenylalanine level in the maternal serum, preconception and antenatal. And of course, monitoring will be more frequent antenatal. Before pregnancy, we test phenylalanine twice per week. During pregnancy, 3 times per week. Okay. Okay, what is your target? My target that pregnancy starts after the woman being controlled. Okay, what if a woman came late? She didn't come before pregnancy. Unfortunately, she came pregnant. Okay, my target is to achieve rapid improvement before 10 weeks gestation. Of course, it's better to come pre-conception, but some women come, she's pregnant, and she gave you the surprise, doctor, I have PQ. Did you come pre-conception? No. Are you controlled? No. Did you assess your level? No. Okay, let's try to make rapid improvement and rapid control before the first 10 weeks of pregnancy. How we do assessment for the level of phenylalanine? Okay, it's by taking a sample, capillary sample, by doing puncture by lancet, either from the finger or from the heel if this is a newborn, because we need to monitor the level in the newborn. Then it's allowed to be dried on a filter paper, then to be tested within 3 hours. After 3 hours, you test the filter paper to assess the level. Okay, before pregnancy, what is your target level before pregnancy? I need the level to be less than 350. To be less than 350. I need 3 to 4 readings confirming that the level is less than this number. Excellent. Now we can allow the woman to start pregnancy. But Dr. Osama, this level is still high. Yes, we didn't say she will be pregnant today. We are still doing control, but we start to allow her to have pregnancy. So still control is done. Still, we are doing diet control. We expect the level will be gradually more and more decreasing. So when pregnancy happens, she is controlled. She is now normal level. Okay. What if after doing this control involvement of dietitian, preventing some types of protein foods and giving her supplementation, frequent monitoring twice per week, and unfortunately, no pregnancy happened. Okay, no pregnancy happened. Within 1 year of control, refer for fertility specialist. Why? To investigate. Because already we are putting this woman under pressure to be controlled. So after 1 year, refer for fertility to help her to have pregnancy. Clear so far? Easy? Easy?
Yes, I have one question, please.
Yes.
You said about serial growth scans. When will we start serial growth scans? Is it from 16 weeks onwards? And also, when we are going to, what are the indications of MRI in such patients? When we will do and when we will say no need of MRI?
Okay. What do you know about MRI? What is your information?
I think we do it just to differentiate between fetal alcohol syndrome and this one, or maybe some other indications also.
Look, during pregnancy, you don't need MRI. During pregnancy, you need echo to the heart at 20 weeks to exclude congenital heart disease. And you need serial growth scan. It usually starts from 24 to 28 weeks to be done each 4 weeks, not early. Okay, not very early. So we start 24 to 28 and usually done each 4 weeks. You may increase if you find abnormality. And very important to measure head circumference. Okay, after delivery, we are not the one that will control the baby. Okay, if the history that the mother has PQ, it's clear, it's PQ. If the mother has no PQ and she is drinking alcohol, okay, it's more towards fetal alcohol syndrome. So management of the child is not our interest. Okay, our interest to achieve good control preconception, antenatal, and to have safe delivery. And alhamdulillah, this condition doesn't affect the mood or the time of delivery. Okay, clear? So during pregnancy, you don't need MRI at all in this condition. Clear?
Yes, thank you.
Okay, thank you. Okay, important question. How many times you test per week the level of phenylalanine? The answer, twice per week. Before pregnancy, 3 times per week antenatal. Okay, you will test amino acid level, vitamin status, mineral, trace element, full blood count, 22 weeks. Before this date, you should assess these levels. Tyrosine supplementation from 16 weeks because this woman has tyrosine deficiency. We said she has deficiency in tyrosine, dopamine, melanin, and body proteins. Okay, give her food containing no or less phenylalanine and give protein supplementation.
Dr. Osama, can I ask?
Yes.
Patient with phenylketonuria, is she capable for to be pregnant? I think you say that there is many neurological problems, and you know, this is a genetic disease. No problem with fertility, no problem with IQ.
Look, as we said, the baby can be at risk of 2 problems. Number 1, having the disease to be inherited. But the good news, it's autosomal recessive disease. So what do you mean? I mean, to have the baby having the enzyme deficiency, the baby should be homozygous. How to be homozygous? The baby needs 2 alleles, one from the father, one from the mother. So if you have a patient with phenylketonuria trying to have pregnancy, tell her, we need to test your partner to see if he is carrier or not. We can do genetic testing for him. If he is carrier, there is a chance that the baby can have the disease, can have the 2 alleles. What if the woman is deceased?
About the woman.
Hmm?
I'm talking about the woman.
Yes. If the woman is deceased and her partner is genetically normal, not a carrier, the baby will not be deceased genetically. At most, the baby can be carrier. Okay, now we solved the problem of genetic problem. The other problem, phenylalanine coming from the mother to the baby through the cord, through the placenta against concentration gradients. It can be controlled by dietitian. Okay, what if the mother is deceased and the partner is proved to be genetic carrier? IVF, BGD can be done to select normal embryos. Clear?
Okay.
Am I clear? So you have 2 problems. You have the genetic problem, so we need genetic counseling, preconception, and the metabolic problem, which needs dietitian and control. We need both problems to be solved. Okay. During the antenatal care, we said by ultrasound, we test for head circumference to exclude microcephaly. What is the meaning of microcephaly? Small head circumference. Okay, what do you mean by small? You should put a level to us to know if this head is small head and microcephaly of PQ or not. Each gestational age has its reference head circumference. This head circumference, according to the gestational age, is called the mean. The mean, المتوسط الحسابي. The mean. Okay, so let's take an example and a statistical point about the mean and standard deviation. Okay, let's look at the babies For example, we are doing ultrasound at 28 weeks. Okay, we are doing a study. We are doing assessment to the head circumference of the babies at age of 28 to know what is the normal. Okay. For example, we had 1,000 pregnant women. We assessed head circumference in them at this age. Okay, and let's say that head circumference at 28 weeks, for example, is 6 centimeters. This is the mean, 6 centimeters. Okay, some children, some babies have 6.1, 6.2, 6.3, and some has 5.9, 5.8, and so on. This is a normal. Okay, it's an example with imaginary numbers. So the mean head circumference at 28 weeks is 6 centimeters. These numbers are not scientifically accurate. I'm giving example. Okay. Distribution of other numbers around the mean is called standard deviation. What do you mean? I can make another curve with the mean 6 centimeters, but distribution of numbers around is different. 6.2, 6.4, 5.8. What do you mean, Dr. Osama? I mean that to draw a curve, it's not sufficient at all to tell me the mean only. No. I need two things. I need the mean and how the numbers dispersed or arranged around the mean. This dispersion and this distribution is called standard deviation. Standard deviation here is different than here. It's clear. Clear so far? You know now how standard deviation can affect the number of the curve? Clear? Clear?
Yes.
Okay. We will know well in statistics how to calculate the mean and how to calculate standard deviation because it can come in the exam. Okay, so here standard deviation 0.1 because 6.1, 6.2, here 6.2 and here 0.1. So 0.2 in this curve and 0.1. Let's say that in the real life, let's say this curve is the right one. So the mean 6 centimeter, standard deviation -1. Look what Satuk article said. Satuk article said we can say this head is small if it's a small 5 or more standard deviations less than the mean. Somebody can tell me, according to this and according to this curve, this one we will use it. If the head circumference for a certain baby is 5 centimeters, microcephaly or not, the mean is 6, but this baby is 5, microcephaly or not?
Not.
No.
Why?
No.
Why?
Because it is only point difference, 5.8, 5.9, just point.
Microcephaly means head circumference 5 or more standard deviation less than the mean. Less than means minus. So the mean minus 5 standard deviation. If the number is less than this is microcephaly. The mean is 6 minus 5 multiplied by 0.1, so it's 0.5. So it will be 5.5. So if the head circumference is 5.5 centimeter or less in this example, this head is microcephaly. So 5 centimeters is microcephaly or not?
It is.
Yes.
It's
Yes,
microcephaly. It's microcephaly. Another example to make it more clear. Okay. We are doing assessment for head circumference at 26 weeks. Okay, and the mean is 7 centimeters. Standard deviation is 0.2. Okay, these are the statistical data. Our case, Mrs. X, she's pregnant 26 weeks. She's having PQ. Okay, and the head circumference for her baby today is 6.2 centimeters. The question, what is your diagnosis? Microcephaly or not microcephaly? Okay, at first, I need to know what is the lower limit for normal head circumference. According to the TOG said, if the head is 5-fold standard deviation less than the mean, this is microcephaly. So what do you mean? 7 minus 5 multiplied by 0.2, 5, so it's 1, so equal 6. So if 6 centimeter or less, this is microcephaly. So this baby is microcephaly or not? What do you think?
No, she is not.
No.
It's more than the lower limit, so not microcephaly. Clear? You can solve it now in the exam. If he gave you the normal mean for head circumference and the standard deviation, now you can calculate, now you can know if this head circumference is microcephaly or not. It's important. It comes in the exam. Okay. Clear? Anybody wants me to repeat? ماشي الحال? Clear? Fine?
Clear.
Clear. Okay. So take care, 5-fold, because you will say different reference when you talk about Zika virus. It has different. In Zika virus, we are talking about 2 standard deviation, not 5 standard deviation. So the diagnosis can be different if you are talking about different diseases. Okay. Okay, delivery, as we said, phenylketonuria doesn't affect mode of delivery, doesn't affect the timing of delivery. So full term, okay, induction, cesarean, normal, no problem. Any mode of delivery can be accepted. And what about breastfeeding? Already, breastfeeding has some phenylalanine. The breast milk, it has some phenylalanine, but to be frank, it's a small level. So breastfeeding is accepted. What if the woman will not have breastfeeding and she wants milk formula? We have a specific milk formula for PQ, that the milk formula will be deficient in phenylalanine. After delivery, we need to test this baby as a newborn and as a child. Up to 14 years, this baby will be kept under vision to exclude any behavioral abnormalities, any neurological problem, even epilepsy can develop, as we said. Monitor the growth, So starting from timing of delivery until age of 14, this child will be kept under supervision. Okay, and even a metabolic consultant will review the mother at 3 months postpartum. Okay, clear so far? We finished the talk article about BKU. It came before in the exam more than once. Let's solve some questions. Who wants to solve number 1? Say your name. Say your name. A volunteer. Don't be shy. Don't be shy, no problem. We are learning. A volunteer? Who's brave? Dr. Maha? Dr. Noha? Anybody?
Yes,
Okay.
yes, I will solve it.
Dr. Noha, okay. Please start by question number 1.
Okay. Regarding phenylketonuria, true or false? It is a deficiency of the amino acid phenylalanine. Is false
So what is
because
right?
it is a deficiency and of the enzyme phenylalanine reductase, I think.
Excellent. So the enzyme is deficient, so phenylalanine itself will be increased. Excellent. Please solve number 2, Dr. Noha.
It is an X-linked recessive inherited metabolic disease. False because it is autosomal recessive, not X-linked.
Excellent. Autosomal recessive. Same like cystic fibrosis, same like sickle cell disease, same like thalassemia. All are autosomal recessive disorders. And now I will tell you what is the meaning of autosomal recessive and how we can apply Mendelian inheritance. Okay, please solve number 3.
It results in deficiency in the amino acid tyrosine. True.
Excellent. That's why dopamine and melanin and the body proteins will be deficient. So risk of IGR, risk of epilepsy and neurological and behavioral diseases. Okay, thank you. Excellent, Dr. Noha. Perfect. Perfect. Thank you.
Okay.
Another volunteer, please. To be brave like Dr. Noha. Who else?
Okay, I will tell.
Okay, Dr. Shazia, welcome. Please, number 4.
Treated with phenylalanine saccharide. This is true.
That's
Then
right. Excellent.
it is instances approximately 1 in 10,000. I think it is not 1 in 1,000. 10,000.
Excellent. 1 in 10,000, rare or very rare. Excellent. Number 6.
The newborn screening program has been a great success in diagnosis and management of child with phenyl. I'm not sure. Maybe it is true. Yes.
That's right. Excellent.
Neonates
We
fetal
tested
full
it, yeah.
syndrome and phenyl is clinically difficult to distinguish at birth. True.
That's right. Excellent. That's why history is important to differentiate. You can test phenylalanine to the mother and taking history if she has a problem or she is alcohol using. That's why during pregnancy, we have to screen for alcohol. How? Screening by history. You ask every pregnant woman in UK should be asked during the booking visits and other visits. Do you smoke? Do you drink alcohol? Do you take any recreation drugs? If she is positive in any one of these, you tell her, did you think of quitting? We have National Health Society stopping services, smoking stopping, alcohol stopping, so they can help you. If you want, I can refer you to them. They can help you. Okay, thank you. Excellent. Thank you, doctor. Perfect.
Welcome. Thank you.
These are the answers. Exactly as you said. Perfect. Okay, who is next? Name? A volunteer, please. Hello? Okay, I will read the question and you can answer. In utero exposure, you didn't see the question yet. Okay, sorry. Somebody had before a case of PQ? Somebody saw a case before? Nobody?
No.
Okay. Number 8, in utero exposure to very high level of phenylalanine results in reversible neurological damage. What do you think? These problems, are they reversible?
I think
What do you think?
irreversible. I think irreversible.
That's right. It's reversible. The brain damage that happened, it's unreversible. It's irreversible. That's why you have to do control preconception. If the woman came already pregnant, you should control before 10 weeks because damage is irreversible. Okay. Pregnancy outcome improved when treatment results in low phenylalanine, ideally before conception. What do you think?
Yes, true.
True, perfect. True, perfect. Oral methods of contraception should be switched to barrier methods at least 12 months before conception. Let me explain this point at first. While we are doing control preconception, we should prevent pregnancy because we don't want pregnancy to happen while the case is not controlled yet. That's why we prescribe OCP, oral contraceptive pills.
Yeah.
Why OCP? Why not progesterone only pills, for example? Because with OCP, there will be
we have regular
monthly
periods.
bleeding.
Yeah.
Yes, she will have periods. There will be monthly bleeding. So we are still sure that she is not pregnant.
And we can plan the pregnancy. Yeah.
Excellent. If you give her POPs, she can have amenorrhea already. Some women with POPs, they don't have periods. So how we will be sure that she is not pregnant? So we prescribe OCP. Okay. So can we continue OCP, then stop it to allow pregnancy immediately? The answer is no. So what to do? After finishing OCP, they start using condoms 3 months. Why? In these 3 months, we are removing the effect of OCP upon the endometrium. OCP, they have bad effect upon the endometrium. That's why we wait until it's washed in these 3 months. Again, how to offer contraception in these women? Take care. I am giving her contraception because she is searching for pregnancy. I am just giving it to confirm no pregnancy to happen until she is controlled. So at first, I will give her OCP. Then I will stop OCP and give her condom 3 months. Then allow her to become pregnant. In these 3 months using condom, I am giving this 3 months time at least to allow clearance of the effect of OCP upon the endometrium to have good endometrium, good implantation, healthy pregnancy. So 3 months, maximum 6 months. The question here saying 1 year. So true or false?
It could be 6 months, not 1 year. False.
Excellent. So 12 months is wrong. Excellent. Question 11. Congenital heart, 7 to 10%. What do you think?
True.
It is true. Congenital heart is 7 to 10%.
True. That's why we need echo to exclude congenital heart disease. Okay. It's an indication for cesarean section.
No, this is false. Normal delivery or IOL.
It doesn't affect timing or mode of delivery. Neonate should be offered screening for PKU as routine. So the baby will be screened. Yes, that's right.
Yes.
We have routine screening for PKU.
Yes.
Breastfeeding is contraindicated.
No, not contraindicated.
We said although breast milk, it has phenylalanine, but it's a small level, so safe to breastfeed. Excellent. Okay. Phenylalanine pass passively through the placenta.
No, actively, because it is small.
Active.
Oh, no, sorry. It passes without any this one.
Active transport. That's
Yeah,
why
active
it's
transport.
1.5
Active
to
transport.
2.5 fold
Active
in
transport.
Active transport.
active transport. That's why
Without
concentration
any
is
support.
higher in the
Yeah.
baby than the
Yeah.
mother. Fetal phenylalanine is 1.25 to 2.5 greater than maternal level. That's right.
Yes.
Mm.
The child will have blue eyes.
True.
Yes.
That's
True.
right. True. Because of deficiency of melanin. Fair skin. That's right.
Also, they are albino, like fair skin, white hair,
Yes.
golden hair.
That's right. Perfect. Okay. Mother
Sorry, Dr.
is
Osama, can you share the screen? I cannot see the questions. Can you share the screen?
Okay, it's clear now. All the question from 8 to 18, you can see it now. It's present.
No.
Anybody else
Yes.
cannot see the questions?
I can see clearly.
It's present. There is just delay in your network. Okay.
What's the problem?
Somebody can read this question, please? A volunteer?
Mother is having.
The
Your
mother
name?
is having.
What's your name? Dr. Sirajam?
Yeah, I'm Dr. Sraja Munira. Mother is having phenylketonuria syndrome and father is normal. What is the risk to their offspring to have the disease is 0%.
Okay, the mother is BKU syndrome. So the mother
Yeah.
is homozygous or heterozygous?
Homozygous.
Homozygous, excellent. So
Father
the
is
mother
normal.
like this, having two affected genes.
Yes.
Okay, her partner
Normal.
So like
So
this.
all genes are normal.
So
So
to
there
make
is
it
no
easy,
chance of getting homozygous gene by the children.
so there is zero chance to have a baby
Yeah.
who is homozygous. Okay.
Yes.
So how to make it? So this woman will give this affected gene to all the coming generation.
Yes.
And the
True.
partner will give normal gene to all the coming generation. So 100% of the coming generation will be
carrier.
Carriers.
So 0% patient.
Yes.
All will be carriers. So this baby is safe? No. The baby is safe genetically, but not safe if phenylalanine will pass through the placenta. So maternal control is important.
Yes, very important.
As you see here, the couple, it's clear that they visited genetic clinic and the partner was tested to be genetically normal. So we can tell them, we can assure you there is 0% chance of having a baby with BKU, but the baby will be a carrier. So what is the problem, doctor? The baby will be normal, but can inherit the gene to the coming generations. So 0, this is a recall question, 0%. It's clear now how to inherit autosomal recessive disorders. Autosomal recessive. So having one abnormal gene is not sufficient to be diseased. You should have 2 abnormal genes to be diseased. Okay. The risk of congenital heart in BQ.
8 to 10%. B.
It's 7 to 10%.
B, I think.
5 to
B,
10%.
So 5 to
7
10%
to
would be the
10%.
appropriate answer.
7 to 10 is not present. So you will
Yes.
choose the nearest one. So it's a 5
Nearest
to 10.
5 to 10%.
5 to 10. It's the nearest one. Excellent. Okay. We finished the topic about BQ. Somebody has any question? I will give a note about Mendelian inheritance. Okay. I make abnormal gene, I put a circle like this, a dot like this. This dot means abnormal gene. So this person having how many abnormal genes? Having 1 abnormal gene. Okay. If I told you this gene is from autosomal dominant disease. So this person normal or carrier or healthy? Autosomal dominant.
Diseased.
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 Yes.
Diseased. Excellent. Okay. If I told you this disease is autosomal recessive, this patient will be
Carrier.
carrier. Excellent. Very good. And always, if I am telling you I have a patient with autosomal dominant disease, assume that this patient is heterozygous. Assume that this patient is heterozygous. Because only 1 gene is sufficient. You don't need to make it very bad by making this person homozygous. Assume this patient is heterozygous as long as he didn't mention if he is homozygous or heterozygous. Clear? Okay, let's talk about a partner or a couple that they have autosomal dominant problem. This is a female patient or carrier.
Diseased.
Diseased. And this male is
Diseased.
diseased. Okay, let's see the coming generation. From here to here, what is this?
Diseased.
Diseased and homozygous. Okay.
Yes, homozygous diseased, yes.
From here to here,
Heterozygous diseased.
heterozygous diseased. Excellent. From here to here,
Heterozygous diseased.
heterozygous diseased. From here to here,
Normal person.
normal. Excellent. So 75% diseased, homozygous or heterozygous, and 25% normal. Perfect. The same scenario. So we find 75% diseased, 25% normal. Okay, same scenario, but we will make it autosomal recessive disorder. What is your diagnosis for this one?
Carrier.
Carrier. And this one?
Carrier.
Carrier. From here to here?
Diseased.
Diseased. From here to here?
Carrier.
Carrier. Here to here.
Carrier.
Carrier. Here to here.
Normal.
Normal. Excellent. So 25% normal.
Disease.
50%
Normal.
carrier. 25%
Diseased.
disease. Excellent. Very good. For X-linked disorders like hemophilia or Duchenne or G6PD, X-linked disorders, male, female, having one affected X, so this male is deceased.
Diseased.
X-linked recessive. Having one affected gene in the female, carrier.
Carrier.
So in X-linked recessive, we need the woman to be homozygous, to be deceased. Only one affected, heterozygous, carrier. Clear?
Yes.
Yes.
In the male, it's more difficult because one gene, one affected X, already this person is having one X. If it's affected, he is deceased. Clear?
Yes.
Clear?
Yes. Yeah.
Okay. I finished. Alhamdulillah, my target today. Somebody had any question?
Doctor, in this thing, there are questions like there is a female and her brother or uncle is affected like this. So we take the population percentage into the probability of the child being affected and probability of her being affected. There are 2 or 3 sets of multiplications. Can you explain those kind of questions, please?
Okay. If I told you that, for example, as you said, her brother or something like that, it means that there is abnormal gene in this family. From the history he is giving to you, for example, he is telling you the mother and the father were carriers. There is a chance that your patient is homozygous. So, if he told you that this disease is autosomal recessive and her brother is affected, she can be affected too. Okay, you cannot say 100% if she is normal or not, but take care. This means she can be affected by the abnormal gene. If he told you mother carrier, father carrier, we know now if autosomal recessive, okay, we have 25% to be deceased, 50% chance to be carrier, 25% to be normal. So 75% will be asymptomatic. So the questions that he is talking about the family, okay, just take care. It means there is abnormal gene. If she had one of them, she will be carrier if this is recessive, and she will be deceased if this is autosomal dominant problem. Okay? Clear?
Yes. Clear.
How we take a population risk in these, like for different diseases, there are different population risks, I guess.
Yes, the risk here will be tailored according to the scenario and according to if this disease is recessive or dominant and who was affected in the family. And put in your mind, at least she can have one abnormal gene. Okay? Clear?
Okay, thank you. Yes, thank you.
Okay, thank you. Oh, please, you can find on YouTube.
Yes. Definitely.
I will upload, inshallah, this lecture on YouTube, and I will put the link on the group. Okay, you can also on YouTube just search for you can find some of my free videos present on YouTube. Okay, this is my channel. intrapartum care, teaching, thalassemia, okay, and discordant sexual development. Okay, this is orientation for part 1. Okay, so you can watch my previous videos. And please, inshallah, who wants to contact me about joining the new course, you can contact me on a private chat on WhatsApp, inshallah. The course will start 2nd of June, inshallah. It will be a lucky group because the duration will be longer. The duration will be 8 months or 7 months and a few days, inshallah.
Inshallah.
So
Thank
thanks
you.
all of you.
Thank you, doctor.
Best wishes for you in your exam and your
Thank
study.
you.
Okay, and happy Eid. Congratulations. Happy Eid, inshallah, happy feast. And Assalamu alaikum to all of you. Thank you.
Thank you.
This conference will now be recorded. This conference will now be recorded.